There is both eye latent nystagmus and a minimal cycloplegic refractive error. Modified Krimsky shows around 45 prism diopters of esotropia. The extraocular muscles movement was full and there is no associated IO overaction. So this is a case of infantile esotropia with right eye amblyopia. It will be managed with amblyopia therapy followed by surgery, and the plan in this case will be a bimedial recession about 11 millimeters from the limbus. So the history and clinical findings are typical for that of the infantile ET, and for all these cases we will give a trial of glasses, correct the amblyopia and then plan for surgery. The best time to operate, however, is controversial, and we recommend usually operating between 6 months to 2 years of age. Bimedial recessions are preferred over unilateral RNR procedures, and studies have shown that the sensory outcome and the motor alignment are good when we do operations in this age group. Emphasizing the surgical considerations, a bilateral symmetrical surgery should be planned. A bimedial recession can correct up to 45 to 50 prism diopters of esotropia, and measurements need to be taken from the limbus. IO weakening procedures are considered wherever there is an overaction because they can cause long-term exotropia. 3 muscle surgery is frequently associated with long-term exotropia, and surgery for any DVD should be deferred as a primary procedure. Children will have a lot of tenons, so we need to be cautious when operating. It can be challenging to locate the muscle. Meticulous dissection is needed to prevent any injury to the muscle, and also subsequent scarring should be minimized because they may need resurgery. A fornix-based incision is preferred because it is easier to close, and the tenons must be well opposed with the conjunctiva along the closure lines. The conjunctival recession can be supplemented with medial rectus recessions. So my second case is a child, 8-year-old, complains of squinting since 2 years. We can see he has a hyperopic refractive error. The deviation for distance is 35 prism diopters, and for near it was 40. The extraocular muscle movement was full, and there is an IO overaction in the left eye. We prescribed full cycloplegic correction for this child, and we see he was ortho for distance with a minimal esotropia for near. So this is partial accommodative esotropia. A similar case wherein we have a 21-year-old female was wearing glasses in its early childhood. The right eye best corrected vision is 6/6 and the left eye is 6/18. So there is an anisometropic hyperopia. Without glasses, her deviation was 60 for distance and near, and with glasses it was 35 for distance and near. So there is a residual angle of 35 prism diopters. This is a case of partial accommodative esotropia where you have residual angle and there is amblyopia in the left eye. She was taken up for surgery, and we planned a left eye medial rectus recession with a lateral rectus resection, aiming for the residual angle of deviation. She was doing well post-operatively with minimal esotropia at 6 weeks. So a few clinical pearls: we should look for hyperopia, we should assess the AC/A ratio, we will prescribe full cycloplegic correction. If glasses correct the deviation, we will not go in for surgery. If the deviation is partially corrected, then the surgery is planned for the non-accommodative residual deviation. Glasses will be needed post-operatively by the patient. Prisms can be tried for the small residual deviation. A bimedial rectus recession is the surgery of choice when planning surgical intervention. However, the standard surgical tables have a high rate of undercorrection for near if the distance deviation is corrected, wherein augmented surgery can be planned where the target angle is the average between the near deviation without correction and distance deviation with hyperopic correction. A few words on distance near disparity esotropia. These are cases where the near esotropic angle is more than the distance angle, more than about 10 prism diopters with a full hypermetropic correction. Now, on the basis of AC/A ratio, the NPA, the response to bifocals, and the magnitude of misalignment for near and distance, these can be further subclassified. If there is an ET with high AC/A ratio, first and foremost, we prescribe bifocals. Surgery is required in cases when the distance deviation is more than 10 prism diopters, even with full cycloplegic correction. Esotropia for near, even with a +3 add, or non-compliance to bifocals. We are aiming at shrinking the gap. So the surgical options here will be augmented bimedial recession, a slanted medial rectus recession, a Fardin's procedure, or a combined resection of the medial rectus, which is the Scott's procedure, MR polyp posterior fixation, or a Y-split recession of medial rectus. Now, augmented medial rectus recession is effective in controlling large distance near disparity with a high AC by A ratio. So, if we are operating for a distance angle, initial scleral bites are taken for the distance deviation. Augmentation of 1 millimeter for the near distance disparity if there is 10 to 20 prism disparity, and augmentation 1.5 millimeters for a disparity more than 20 prism diopters. So by this, every 1 mm will give us around 3.2 to 4.8 prism diopters more correction. In a slanted medial rectus recession, the superior pole of the rectus muscle is recessed for distance deviation and the inferior pole for the near deviation. This is effective in cases where you have convergence excess esotropia. The Fardin's operation is where the rectus muscle is secured to the sclera about 12 to 14 millimeter posterior to the insertion. This will shorten the arc of contact, reduce the rotational force. So the bimedial recession will be based on distance angle and the posterior fixation suture will be based on the near deviation. Scott's procedure is a modification of Fardin's where you will have a large resection of a rectus muscle followed by its recession using hangback or adjustable technique so that the recession amount is more than the resection amount. This will weaken the muscle in the field of action with a minimal effect in the primary position. The point of insertion is moved back without any slack, but the same mechanical effect of Fardin is retained. This next case is a 24-year-old female with invert squinting since early childhood. There is poor vision in the left eye, large angle esotropia, and the extraocular muscle movements were full. This was a case of sensory esotropia, and it can be managed either by a large resection in the left eye or a muscle transplantation wherein the lateral rectus resected muscle can be transplanted to the medial rectus and then recession will be done. We went ahead with a large medial rectus recession and lateral rectus resection in the amblyopic eye, and she was doing fairly well post-operatively. So in these cases, we do operate for cosmetic correction. When we operate, we choose the amblyopic eye, targeting for an angle of 8 to 10 prism diopters ET. And since it is a large recession resection, palpebral fissure changes might be noted. The next case is a 10-year-old boy who had sudden onset diplopia for 1 year and has a preceding history of fever. He has a large angle of esotropia and bilateral inferior oblique overaction. Since it was acute onset and diplopia, we ordered a neuroimaging wherein we found multiple hyperintense lesions. We checked the systemic features for hyperpigmented patches, leash nodules, and 2 plexiform neurofibroma. So this is a case of acute comitant esotropia in NF type 1. We took the child up for surgery with a bilateral medial rectus recession, lateral rectus resection, and inferior oblique recession. This was his post-operative picture, and he was doing fairly well at 6 weeks with ortho for distance and near. So AACE can be associated with neurological pathologies, hence a careful systemic evaluation and neuroimaging is a must. We should wait for the angles to become stable, usually for 6 months follow-up. And we need to be cautious when operating 4 muscles because the chance of consecutive exotropia is high. This case is a 46-year-old male. He has poor vision in the left eye is fixed in adduction, and the axial length of left eye was more. So this is myopic strabismus fixus. Here the surgical options include a loop myopexy, a partial gentian or a Nishida's, or a hemitransposition of the split lateral rectus and superior rectus muscle. So the surgical plan which we opted was a left eye loop myopexy with medial rectus recession since the MR muscle was tight on FDT. There is a large residual angle esotropia post-operatively, and we will have to subsequently plan the right eye. So here loop myopexy, it is a muscle belly union wherein the superior rectus and lateral rectus muscle belly will be sutured to one another by non-absorbable material. The next case is of a 26-year-old female with invert. Just 2 more minutes. Just 2 minutes. So this is a 26-year-old female. So this is a 26-year-old female. She has deviations in cycles as per her. So we examined her on her squint days as well as on her straight days. So this was a provisional diagnosis of cyclic esotropia. Now the treatment options which we have include a botulinum toxin, a bimedial rectus recession, or a unilateral RNR procedure. The surgical dose will be based on her deviation on the squinting days. So after multiple examinations, we chose to do the botulinum injection for this patient, and post-operatively at 6 weeks follow-up, there was no squinting noticeable to her or parents, and she was ortho. After prolonged APCT, of course, we elicited 20 prism diopters of esotropia. So the takeaway pearls, we need a detailed history, sensory and motor evaluation to diagnose the type of esotropia. Look for any associated inferior oblique overaction, nystagmus or facial asymmetry. Complete cycloplegic refraction with atropine or cyclopentalate and correction of refractive error amblyopia treatment before proceeding for surgery. We operate only when the angles become stable. Pre-operative FDT is a must. If the squint is partially corrected, surgery is done for residual deviation. Bimedial recessions are preferred over unilateral RNR procedures. Slanted recession and Farden with or without medial rectus recession is effective in decreasing the near distance disparity regardless of the level of AC by A ratio. Augmented recession and Fardens is effective in controlling a large distance near disparity with high AC by A ratio. Now for esotropias with patterns, if there is a V pattern, we will shift the medial rectus down and the lateral rectus up. If there is an A pattern, we shift the medial rectus up or lateral rectus down. For horizontal muscle surgery, one needs to be very cautious because of chance of consecutive XTs. Thank you.